Okay. Um, Thanks. Today we're going to talk about, well, it's a rare disease. Spinal muscle atrophy is a real important disease for showing how we can deal with a monogenetic disease that has lots of implications on the musculoskeletal system. And the real interest is that we now have disease-modifying therapies um, that specifically modify the genetics. So while it's a bit of a rare disease, it represents how we can approach these diseases. These are my disclosures. So spinal muscle atrophy is an autosomal recessive neurodegenerative disease because of the absence of the survival motor neuron gene. Survival motor neuron protein is key to the development of multiple cell systems, but specifically for the development of the neuromotor axis. And it is characterized by degeneration of the alpha motor neurons in the spinal cord, which result in atrophy of skeletal muscle and muscle weakness. So normal, unaffected humans, we have two SMN1 genes and several so-called rescue gene copies. In SMA, what happens is the SMN1 gene becomes deleted or mutated because of issues at exon 7 or 8. And we have rescue genes, the survival motor N2 rescue gene, which produces mostly a non-functional form of survival motor neuron protein, and the extent of clinical involvement depends on the number of these rescue genes. If you have less than 3 copies, generally kids are severely involved, whereas 3 or more copies, the effects are mild. Traditionally, SMA has been classified by the age of onset in the spectrum of clinical severity. Most children have symmetric weakness where the proximal muscles are weaker than the distal muscles and lowers are more affected than uppers. So traditionally, type 1 were kids who had 2 or fewer copies of the rescue gene. Those kids presented very early as the floppy baby. Those children never sat. There was often significant respiratory insufficiency, sometimes requiring tracheostomy, and there was a high incidence of mortality. Type 2 are children who have 3 copies. Little later presentation, those children can sit without support, but they never stand. And there's variable degrees of respiratory weakness, but many end up on nighttime support using BiPAP. The so-called type 3 kids, later onset, have 3 or more copies. Um, those kids often stand and walk, but later in life may lose that ability to ambulate independently. And when you watch them walk, they have a classic weakness pattern with a Trendelenburg abductor lurch and a hyperlordotic gait because of gluteus maximus weakness. The big issue really that changed what the clinical presentation of these children was the advent of disease-modifying therapies approved first in 2017, which essentially increase the level of survival motor neuron protein. And the efficacy depends on the age of administration because we're trying to prevent death of the motor neurons. Because of the importance of age at administration, all 50 states in the US now have mandatory universal newborn screening. Nusinersen was the first drug. It goes under brand name Spinraza. It's an antisense oligonucleotide that uses an SMN2 mRNA splicing to enable production of a more functional survival motor neuron protein from the SMN2 gene copies. It's delivered intrathecally biweekly for the first 2 months, and then 3 times a year for life. Bristoplam, which came out a little bit later, is a small molecule that works similarly to nusinersen, that basically enhances production of more functional survival motor neuron protein, and it's administered enterally. Zolgensma, is the it takes an AAV9 adenovirus vector to deliver the SMN1 DNA directly to transfect cells so that we can now have continuous survival motor neuron protein production. That has to be administered intravenously one time, and typically it's babies less than 2 years, but really we need to do this in the first 6 weeks. Part of the issue is AAV9 is an adenovirus, so because the common cold is an adenovirus, you can get antibodies to it. So babies, if they've been exposed to the cold virus, can make antibodies against this. So you want to really give this as early as possible. The musculoskeletal issues with SMA are contractures because of lack of movement from weakness, fragile bones because the kids aren't loading their bone during activities of daily living and standing, hip instability, which has coccyvalgia, which you see the more vertical orientation of the head neck, and shallow acetabulum leading to subluxation or dislocation, and then scoliosis, which is going to be the main topic that we talk about now. But SMA is a multi-organ disease with multi-system comorbidities. And when we're planning and thinking about treating these kids with surgery, we have to be cognizant of that more than half will have pulmonary complications. They often have issues with feeding and need G tubes. They can have weak bones. And it's these chronic conditions that often will prolong their hospitalization and account for excess resource utilization. And you need a team of doctors of multi-specialties to deal with the multi-system involvement of SMA. So early onset scoliosis in the era of of the DMTs, is interesting in that what we're starting to see in a number of papers is that the disease-modifying therapies may not actually mitigate this early onset scoliosis and perhaps actually make it more prominent. So early onset scoliosis is defined as a spine deformity before age 10, but in these kids, we're seeing it often at a very young age, as young and often under age 3. It's most common in the kids who have significant weakness, the SMA 1s and 2s, and it's a multiplanar deformity where scoliosis describes the coronal plane deformity, kyphosis describes the sagittal plane deformity, and then torsional deformity is the rotation is seen in the transverse plane. But any single spine deformity really has these three attributes. It's one curve, but the way that we describe it depends on its projection on the AP and lateral X-rays or a CT. The more severe the weakness is, the earlier the onset and more progressive the deformity. And it's the spine pathoanatomy that actually contributes to morbidity and mortality. What we're also seeing, however, is that there are other associated skeletal deformities. And we see this in this 2-year-old child. There's the pectus carinatum, the so-called pigeon chest, a small jaw or micrognathia, and then most of these kids have the hip issue with the coccyvalgia and acetabular deficiency. We think that the SMN2 gene copy number may actually be a biomarker for onset and severity, and that the mitigating effect of DMT has been inconsistent in modifying this relationship between the SMN2 gene copy number and the subsequent skeletal deformities. We're also seeing this unique pattern that has emerged, and this was a study that we did in 51 of my patients who were coming to spine surgery. And about half the kids are now having this high thoracic kyphoscoliosis compared to the classic C-shaped thoracolumbar scoliosis. And these are severe deformities where a number of the patients are presenting at a very early age with kyphosis and scoliosis exceeding 90 degrees. We think that this high thoracic kyphal scoliosis actually represents a skeletal phenotype that's linked to the number of the SMN2 gene copies and the age of DMT administration. And in our study, we noted that children who had less than 3 copies of SMN2 and received disease-modifying therapy earlier than age 1 actually had an increased likelihood for this high thoracic kyphal scoliosis compared to patients who had 3 or more SMN2 gene copies. Now, part of this could represent a survival bias because prior to the advent of disease-modifying therapies, children with less than 3 copies of SMN2 frequently didn't survive. So in our cohort, 51% of the children who had less than 3 copies received disease-modifying therapy, whereas in our natural history cohort, only 18% received the survived long enough to develop a scoliosis. Whereas in the disease-modifying therapy cohort, 82% of the natural history had 3 or more SMN2 copies. The other thing is the kyphosis was much more severe among the DMT patients. So the next question then is, does DMT actually mitigate early onset scoliosis in SMA children? We know that the clinical trials show improved survival and motor function associated with early DMT administration, especially before age 6 weeks, a higher number of SMN2 gene copy numbers, and also symptom status at birth, where pre-symptomatic babies seem to have better outcomes. Our hypothesis then was, does early DMT actually mitigate the development of early onset scoliosis, subject to the effects of gene copy number, age of DMT administration, and symptom status at birth? And we also looked whether any motor function, such as independent sitting, mitigated risk. So basically, your immutable factors are your gene copy numbers, and we broke it down into less than 3 copies or 3 or greater, and symptom status at birth. The intervention is the type of DMT and the age of administration. And then we saw whether there was any mitigating effect by motor functions measured by the Hammersmith functional motor scale. So in 129 patients, 34% received early DMT and 66% received DMT older than age 6 weeks. And of that group, 65% developed early onset scoliosis, essentially by age 2, with curves measuring on average about 33 degrees. If we adjust for the age at DMT initiation, there doesn't seem to be an association between the DMT type and early onset, but the age at which DMT is given is very important, where if it was provided before age 6 weeks, there was a much lower risk of developing scoliosis, 33% in the early group versus 82% in the late administration group. So for children who got early DMT, in children with less than 3 SMN2 copies, the early DMT only reduced the hazard by about 51%, whereas in children with greater than 3 SMN2 copies, early DMT basically prevented early onset scoliosis. And symptomatic versus asymptomatic, we really didn't have a clear analysis because we were underpowered. So among infants treated after age 6 weeks, though, DMT initiation, whether it was at 7 weeks versus 7 years, did not lessen the risk of early onset scoliosis. So basically, DMT administered before age 6 weeks is key to mitigating the early onset scoliosis. In children with less than 3 copies, it helped reduce the onset by 51%. But in children who have 3 or greater copies, early onset DMT was preventative. What this suggests is that the SM2 copy number is a biomarker for SMA skeletal pathoanatomy and responsiveness to treatment, and whether you sat or not really had a minimal mediating effect. So this suggests that children who are at high risk and need to be followed carefully for early onset scoliosis are those children with less than 3 copies received DMT later than 6 weeks. And these are the children we need to keep a close eye on. So what are the consequences of scoliosis and SMA? So larger curves actually are also associated with hip and pelvic deformity that compromise sitting, posture, and balance, and reduce function, where these kids often need their upper extremities to support their trunk because of weakness, and we call this tripod support. And this can interfere with bimanual arm and hand function because of the pelvic obliquity and poor muscle coverage of their buttock. They can actually develop ischial decubiti. But the thing that kills these kids is the cardiopulmonary compromise, so-called thoracic insufficiency. These children can have difficulty with feeding, having gagging on swallowing because of the bulbar effects of spinal muscle atrophy. Because of kyphosis and poor head control, they can have difficulty managing their secretions, resulting in sialorrhea, and they can also have back and buttock pain. So thoracic insufficiency syndrome is an extrinsic restrictive lung disease that's seen in early onset scoliosis, but particularly in children with spinal muscle atrophy because of the associated rib deformity in addition to the spine deformity. The scoliosis alone does not predict the extent of respiratory deficiency because the Cobb angle fails to account for the chest wall deformity that interferes with pulmonary growth. And what happens is the curve gets so severe that the ribs are essentially resting against the ilium, which limits excursion and the mechanical function of the diaphragm. So the thorax is unable to support normal respiration, ventilation, and lung growth, contributing to a restrictive lung disease and respiratory dysfunction. In the normal growing child, the thorax enlarges for lung growth, where the rib cage provides the width and depth, and the thoracic spine provides the height. So failure for thorax to grow causes an extrinsic restrictive lung disease. And the diaphragm functions as a piston, accounting for 85% of the change in thoracic volume during ventilation. The rib cage functions as a billow, where the rib intercostal rib is the biomechanical unit that basically functions as a bucket handle. So the scoliosis limits diaphragmatic excursion, and the deformed rib cage limits the efficacy of the billow. In normal lung and thoracic growth, these are interdependent. From birth to age 8, we have alveolarization, which increases the number of the alveoli, which is important for gas exchange. But new alveolar growth ceases by age 8, but the thorax is only 40% of the adult size at age 8. From 8 years through maturity, the lung itself grows by alveolar hypertrophy, where the lung volume increases with the growth of the thorax. So what this suggests is interventions to correct early onset scoliosis and prevent thoracic insufficiency should be undertaken before age 8 years. Pulmonary function metrics vary with thoracic volume and the height and spine length. PFTs are reported as percentiles based on the height, either standing, sitting, of the spine. But in SMA, these normative percentiles are meaningless because of the scoliosis and contractures. A study done at Boston Children's Hospital 2 decades ago demonstrated that the pelvic inlet width correlates with the predicted normal spine height and stature with growth, independent of disease or age, and this can be reliably measured on both spine and/or hip X-rays and becomes a useful surrogate for what the appropriate thoracic height should be in a growing child with SMA. If we plot pulmonary function versus pelvic inlet width for normal children, you can see that there is a linear relationship where for every 1 unit increase in pelvic inlet width, there's a 22% increase in forced vital capacity, which is an important measure of pulmonary function. However, in severe scoliosis, you can see that when the Cobb angle is greater than 50 degrees, it lowered the forced vital capacity by nearly 19% compared to the yellow dots, where the effect on forced vital capacity was less prominent. So for scoliosis greater than 50 degrees, pulmonary function is unable to change in proportion to the change in height with growth, and this is thoracic insufficiency. What was disappointing was when we do spinal instrumentation to try to mitigate the deleterious effects of scoliosis and forced vital capacity, where we take a 90-degree curve and reduce it to less than 30 degrees, we still were not able to get back to this normal relationship between the volume and height of the spine versus forced vital capacity. At best, a 1 unit increase in pelvic inlet width was associated with only a 15% increase in forced vital capacity, which is significantly different and less effective than normal growth. Part of the reason for this is children with SMA have a spinal deformity, which we call paracel rib deformity. And we did a study where we were able to come up with a metric that we call the paracel rib score that looks at this so-called pigeon chest, or not pigeon chest, but this bell-shaped chest, where you can see that the collapsing rib limits the volume available for the lung to grow. A lower paracel score equals worse chest deformity, whereas a higher score is less chest deformity. But we were able to show that a paracel rib score of less than 0.56 predicted the need for assisted ventilation with 73% sensitivity and 100% specificity. So spinal instrumentation using either spine or rib-based anchors actually did not really improve the paracel score. And this remains an issue that we have to think about in future work. So what are the goals of spine deformity treatment? We want to have a balanced spine with the head over the pelvis, a level pelvis with symmetric pressure at the buttock to help improve and preserve pulmonary function, relieve pain at the hips and spine, facilitate positioning and transfers, and eliminate the use of the upper extremity for support. Biomechanically, what we're trying to do is apply a corrective bending moment to basically straighten out the spine, and that can be accomplished by applying a 3-point bending moment at the apex of the convexity and or distracting across the concavity. So we can accomplish this non-invasively using braces or casts. This is essentially palliative as opposed to preventative. It prevents progression of the deformity and allows for growth of the spine in the growing child. And our work demonstrates that you need about 30% in-brace curve correction and using the brace for about 7 hours a day to be effective in delaying surgery for at least 2 years. And then we have the invasive spinal instrumentation, either the growth-friendly devices that we use in growing children, which are an internal splint that partly corrects the deformity, halts curve progression, but allows for continued growth of the spine by virtue that we can keep growing and lengthening the instrumentation, compared to spine fusion that we would do in a child older than 10, which is the definitive correction of the deformity and halts further spine growth. If you're going to use an orthotic or a TOSO, there's some important principles. First of all, this is palliative, it's not preventative, but we use it as a way to allow the child to grow so that we can hopefully delay surgery until they're at least older than 10, where we can do one operation. The brace itself can improve postural stability and tolerance to sitting and standing, and this allows for bimanual hand function. There are important design features to consider. We want to have this large anterior window to allow for diaphragmatic breathing. We want to apply an anti-scoliosis moment couple where the pad pushes below the apex of the curve, and on the lateral side opposite this, you need to have a hole to allow the trunk to shift over. From a physics point of view, we're basically applying a moment couple to correct the deformity. And you can see we can get pretty good correction because these are low-tone kids. Also, we want to control kyphosis. So the anterior trim line has to be at or below the sternal notch, but the posterior trim line, which is the fulcrum, has to be at or below T9 so that we're creating an extension moment. Our work has shown that if you can wear the brace 7 hours a day, which is during waking hours, because many of these kids are on BiPAP or G-tube fed at night, and you're getting a 30% reduction of the deformity as confirmed on a sitting X-ray with your brace on, we have been able to delay progression of the curve for at least a few years so that we can then try to do a one and done surgery. You do have to be wary about exacerbating paracel rib deformity, so we use a concave pad to kind of push the rib up and over rather than pushing it down. We've also been shown that the TLSO can improve function as measured by Hammersmith functional scores. We did a retrospective study at Children's Hospital of Philadelphia and Boston Children's, where we essentially had 20 in a brace group versus a non-brace group, where we looked at the change in the Hammersmith scores before and after bracing. Basically, the kids who were non-braced actually started out with a higher score. They were more functional, had better trunk support, whereas the bracing kids tended to be less functional. But children with the TLSO experienced a slower decline in functional status. So what are the indications for spine surgery? When the expected benefit outweighs the negative consequences, natural history, and surgical risk. So we think this is for progressive scoliosis greater than 50 degrees based on our pulmonary function research, which showed that 50 degrees seems to be the break point. Hyperkyphosis greater than 80 degrees, when spine deformity starts interfering with seating and upright posture. If you've tried bracing and it's failed, you need to have adequate hip range of motion for sitting, and we'll go into this later. And then we want a stable medical status, both nutritionally, from a pulmonary point of view, and good bone quality. So first, we have to preemptively manage comorbidities. There's a 27 to 40% incidence of perioperative complications. So careful pre-op planning helps avoid postoperative complications, where lung is the most important thing to look at. Many of these kids need to be on BiPAP, and if there's any upper airway obstruction because of tonsillar hypertrophy, we would do a tonsillectomy up front. It's important to have good nutrition, and ANC needs to be greater than 1200, serum albumin greater than 3 to allow for adequate wound healing, and many of these kids need a G-tube. If they have issues with constipation, we would do Miralax or something preoperatively to make sure that they don't have constipation that can be brought on by use of narcotic analgesics after surgery. While relatively rare compared to muscle diseases like Duchenne's, we do an echocardiogram to make sure there's no cardiomyopathy. And many of these kids have poor bone quality with osteopenia, and up to 30 to 40% can actually have fragility fractures. So all kids end up with vitamin D supplement, at least 2,000 international units daily. And if they have very low bone density, they're put on bisphosphonates preoperatively to try to prevent fragility fractures and improve the implant purchase in the bone. Dubuisset, a number of years ago, introduced this concept of deformity above, within, and below the pelvis. So scoliosis is suprapelvic deformity, but asymmetric hip dislocations or adductor contractures can actually cause intrapelvic deformity that can affect lumbar scoliosis and lordosis. And then we have infrapelvic deformity, where contractures related to hip flexion, such as the iliopsoas, can cause increased lumbar lordosis and anterior pelvic tilt. And hamstring contractures can cause decreased lumbar lordosis and posterior pelvic tilt. And his important point is that you should decouple the pelvis and contractures below the pelvis from the spine when you're instrumenting the spine. And often in these children, when you're going to the pelvis, it's important to decouple these contractures. So you address the intra and infrapelvic deformity before instrumenting the spine by either doing an adductor tenotomy or an iliopsoas tenotomy at the pelvic brin and lengthening the hamstrings medially and laterally through a small incision at the popliteal fossa. We'll often do staged procedures. Here's a child with 100-degree high thoracic kyphoscoliosis. These children have the spinal cord is actually tethered and over the apex of that deformity. So rapid correction increases the risk for spinal cord injury. So we'll do preoperative halogravity traction at a 50% body weight for about 3 to 4 weeks with frequent neurochecks. And you can see this dramatically reduces the deformity by often 50 to 60%. And then we do this dual growing rod construct, which we'll talk about using the magic rods. Because this child had poor head control, we extended the instrumentation up into the cervical spine. It's important to practice safe surgery with intraoperative precautions. We use a total intravenous anesthetic technique, make sure that potassium is appropriate, replace blood loss with blood, often using cell saver, but we have a low threshold for giving blood products. We use tranexamic acid as an antifibrinolytic during the surgery to maintain clotting, and we use pneumatic compression boots during surgery. Many of these children may have adrenal insufficiency because of their pulmonary function. They've been getting pulmonary steroids. So it's important to mitigate this by giving stress steroid coverage. Malignant hyperthermia is less of an issue in spinal muscle atrophy. Neuromonitoring is very important. We look at both somatosensory evoked potentials as well as transcranial motor evoked potentials. We often measure the anal sphincter to help prevent any urologic dysfunction. And when combined with SSEPs, we actually can have fairly good uh, monitoring of spinal cord function during correction. Growth-friendly devices are either using spine anchors or rib anchors. It's indicated for a child less than 10 years with severe scoliosis unresponsive to bracing. It's equivalent to an internal splint, and it's a non-fusion technique where you span the entire curve with limited proximal and distal spine fixation, allowing for growth of the spine and thorax. We typically recommend 4 to 6 anchor points above and below. These can be either to the rib, spine, or pelvis. The rods are inserted above the paravertebral muscles. We use a dual rod construct to enhance stability, and the rate of growing the rod depends on the system used. If you're using the so-called magnetic actuator, I often will lengthen these kids every 2 to 3 months, about 3 millimeters. Traditionally, with the traditional growing rods, every 6 months, we try to lengthen these kids about a centimeter. Same thing with the so-called vector device. Um, there are also these guided growth surgical technique. The old school was the Lenke trolley. There's also now been the Schilla technique. Um, Essentially, in these, there's a midline dissection of the lamina preserving the facet joints, where you can either use bilateral sublaminar wires at each section, and these dual rod constructs acts as a trolley for guided growth. Um, Often, it's important to instrument to the ilium to prevent so-called crankshaft. You want to leave the rods long above to allow over time for growth. And this is a one and done surgery in that it obviates the need for lengthening either magnetically or with surgery such as the traditional growing rod. And this is that same patient 9 years later where you see that they've essentially grown off the upper construct, but you've been able to guide the growth and prevent progression of the deformity. There's some important surgical technical considerations. We use intraoperative halofemoral traction, where the traction is applied to the concave side, about 50% of body weight, which is distributed relatively equally between the halo and the femur. If the thoracic curve is predominant, I'll have more weight on the halo. If the lumbar curve with pelvic obliquity is prominent, I'll have more weight on the femur. It's important to have a dual rod multi-segmental construct to disperse the corrective forces and moments over several anchor points. You can use sublaminar wires or bands, hooks, or pedicle screws. Pedicle screws are preserved because it provides 3-column fixation. You want to instrument the entire spine, and whether you go to the pelvis or not depends a bit on whether there's pelvic obliquity and the lumbar deformity. For growth-friendly instrumentation, the instrumentation is above the muscle fascia, except at the proximal and distal anchor points. And it's important to have at least 6 anchor points proximally and distally so that you have adequate control. And the sacral pelvic fixation is indicated if the pelvis is part of the curve, and it will help prevent crankshaft in younger patients. Fusion can be with autogenous or allograft bone, and we have been using antibiotic beads of calcium sulfate impregnated with vancomycin and gentamicin that's released slowly over 40 days to help prevent deep wound infections. Pedicle screws allow you to have 3-column fixation where hooks put either supra or infralaminarly tend to be a little bit sloppier. Sublaminar bands is another option if there is poor pedicle anatomy. So you choose your anchor based on the pathoanatomy to be corrected. Pedicle screws allow three-column fixation. You have greater bone fixation, and it allows the transmission of the 3D corrective forces in moments. But this can be corrected. This can be somewhat technically demanding. It's important that the pedicle not be breached because you can cause impingement on the neurocanal. Um, we check for this by stimulating the screw with EMG. We'll often get transaxial CTs, the O-arm, and if available, stealth navigation with cannulated screws can improve the accuracy of the placement of the screw within the pedicle in poor osteoporotic bone, which these kids have. Sometimes you need to protect the screw against pull-out using a sublaminar wire. And in small pedicles, you may need to use an in-out-in technique. This is best with a navigated approach using cannulated screws, where you can choose to use hooks or bands to avoid risk of breaching the pedicle. Increasingly, we're using virtual or augmentative reality to help with the accuracy of pedicle screw placement. And this decreases by up to 2% the risk of a malpositioned screw. Proximal junctional kyphosis is also an issue in these kids who have poor head control, and it's defined as a Cobb angle greater than 10 degrees above the upper instrumented vertebral level. It can affect up to 30% of children with early onset scoliosis. Risk factors include patient-related functions such as trunk weakness, increased cervical lordosis, hyperkyphosis greater than 50 degrees, a higher pelvic incidence, and poor bone quality. And surgical-related issues are if you disrupt the proximal soft tissue tether by taking down the interspinous and supraspinous ligament complex, excessive kyphogenic posterior distraction, and overcorrection of the sagittal kyphosis. We found that also if the upper instrumented vertebral level was below T1, this increased the risk. So based on our model for who got PJK, we found that if a patient had a global kyphosis of greater than 90 degrees, a cervical lordosis of greater than 40 degrees, and we achieved greater than 50% correction of the sagittal deformity on the preoperative halo, it was important to instrument above T1, so we will often go up to the C5 level or into the lordotic portion of the cervical spine. So in this kid, we did our preoperative halo traction, got a impressive correction. So in this case, we splinted the cervical thoracic junction by putting instrumentation up to C5 and using sublaminar bands to allow for guided growth in this composite, where we used the magic rods to correct the main deformity, but allowed for guided growth to prevent falling off into PJK. When you instrument to the pelvis, this is often dictated by the coronal plane deformity, as well as the child's ability to ambulate and whether the pelvic obliquity is greater than 15 degrees or less than 15 degrees in the relative flexibility. So in an ambulatory patient with the curve proximal to L5 with a level pelvis and stable hips, we try to preserve lumbosacral motion, and we'll try to end our instrumentation at the L4 level. In a non-ambulatory patient with stable hips, where the curve extends to L5, but the pelvis is not part of the curve, we'll often try to stop at L5, or perhaps include S1, but do not include the pelvis directly. But in a non-ambulatory patient with a collapsing deformity, where the curve actually includes the pelvis and pelvic obliquity is greater than 15 degrees, we will go down to the pelvis, and there are multiple options for capturing the pelvis. We prefer to use the S2 Ayler screw, but you can use traditional iliac screws or so-called Dunn-McCarthy technique. Hip spine syndrome is also common in SMA. The hip deformity can actually influence the scoliosis, where the asymmetrically dislocated hip can cause pelvic obliquity, leading to lumbar scoliosis. But the spine deformity can also contribute to hip instability, where the lumbar scoliosis causes pelvic obliquity, contributing to windswept deformity, and the increased lumbar scoliosis increases the risk of hip dislocation. It's important to remember that in transitioning from sitting to standing, there's coordinated spine pelvis hip motion, where in standing, the lumbar lordosis is increased and you have an anterior pelvic tilt. And then in sitting, the lumbar lordosis decreases with posterior pelvic tilt. Pelvic motion changes version and inclination. This causes the acetabulum to posterior rollback to help stabilize the hip in sitting posture. Problem is when we instrument down to the lower lumbar spine and pelvis, we prevent this change in lumbar lordosis and eliminate the posterior pelvic tilt in sitting balance. And if you have a dysplastic acetabulum with posterior deficiency, this cannot accommodate and the hip dislocates. So often when we do instrumentation down to the lumbar and pelvis, we can actually cause a previously asymptomatic, unstable hip to become symptomatic. So I warn our patients about this, often saying that they may require subsequent hip surgery to stabilize the pelvis, since they have a predisposition to skeletal dysplasia by virtue of the skeletal manifestations of SMA. When we do these surgeries, we often need to reconstruct both sides of the hip, addressing both the femoral deformity of the coxavalga as well as the dysplastic acetabulum. For children who are getting nusinersen, where they have to have intrathecal administration 3 times a year via a lumbar puncture, instrumenting down to the pelvis can often obstruct this. Many of these kids require then their intrathecal administration to be done asleep in the operating room under fluoroscopic guidance. One way to help mitigate this is to make a small laminotomy at L4 and fill it with fat graft. But Biogen, which makes the nusinersen, has also developed an intrathecal portal system that allows for the administration of Spinraza intrathecally through this portal, negating the effect for anesthesia and fluoroscopy to administer the Spinraza. It's important to manage these kids post-operatively. You have to pay attention to their volume status. They can often get fluid overloaded. Replace blood with blood products. What's unusual in many kids with neuromuscular diseases, they can get a relative ADH, or where the body thinks that it is volume depleted and will basically hold on to fluid, which causes hyponatremia because of decreased urine output. Many times there's a tendency to give crystalloid boluses, which just then further dilutes the osmotic tension of the blood that then causes third spacing. So It's important to keep a Foley in to monitor carefully urine output. Um, Many times, what these children need is blood products and some Lasix. We use antibiotics. We often use cefepime because these children are high risk for getting gram-negative, and the cefepime is often for 3 days as long as a drain is in. It's important to be aggressive in terms of chest PT and pulmonary toilet using cough devices and extubate to BiPAP. Complications um, historically have been high. We've now been able to get these complications down with aggressive pulmonary toilet. So cough devices, chest PT, BiPAP are important to prevent this. Um, these kids can have an ileus. So if they have prolonged ileus more than several days, you may want to consider um, TPN. We use G tubes for feeding, and if they don't have a G tube, you may need to use a nasogastric tube. Uh, Healing can be a problem because of poor skin integrity with infection rates as high as 11%. There can be excessive blood loss because of the osteoporosis and fatty replacement of muscle because of the atrophy. Death is not such a big deal in this modern era, but in resource depleted regions that don't have access to some of the advanced technologies, these kids can get pretty sick and die. Pseudoarthrosis is less of an issue now that we have pedicle screw fixation. Outcomes, though, are generally quite good with excellent corrections, about 65%, and avoidance of complications with appropriate preoperative planning and aggressive postoperative management. Thank you very much for your time.